Okay, the next presentation we're going to, concepts we're going to talk about is assessment and management of patients with allergic disorders. You have a handout that is called Types of Hypersensitivity Reactions, and it's got 4 listed across the top of it, and we're going to discuss those, so you need to have that handout with you as we talk about this particular component. All right, it's in page 203 in your book. Where it begins to talk about the normal immune response and the antigens and the lymph organs and the types of immunity. Make sure you need to review that. And table 14.1 on page 204 talks about the different types of acquired specific immunity, natural, artificial, or active and passive. So make sure you review those. And then this chapter gives you a review again of all those cells involved in the immune response that we've talked about. On page 206, it talks about table 14.2, the characteristics of immunoglobulins, and you know that the largest component, IgG and IgM in your body, are the ones that help to maintain immunity, and you need to know what the characteristics of each of those are. On page 207, figure 14.4, it talks about, it's a picture of showing you how interferon actually works. And then starting on the bottom of 207, it again talks about comparing humoral and cell-mediated immunity, and this is the component of the specific immune response. And also table 14.5 on page 208 is comparing those as well. We've already been over these, so you are all okay. On page 209 in your textbook and 217 in the old textbook, it talks about hypersensitivity reactions. And a hypersensitivity reaction is an allergic reaction that's manifested by tissue injury that results from an interaction between an antigen and an antibody. An example could be poison ivy. So the allergy is an inappropriate and often harmful response of your immune system to a normally harmless substance, which is called an allergen or an antigen. And this is, we talk about goldenrod or ragweed, or some of you are allergic to grasses and the trees and different things. So when your body is invaded by the antigen, a series of events occur in an attempt to 1, render the invader harmless, 2, to destroy it, 3, to remove it from the body. When B lymphocytes respond to the antigen, what are produced? That's correct. Antibodies are produced, and so the plasma cell stays in the lymph node and is an antibody-producing machine. That's the plasma cell created in response to this antigen. Common allergic reactions occur when the immune system of a susceptible person responds aggressively to the substance that is normally harmless. So some of us are allergic to dust and weeds and pollen and dander, and we just talked about that. The chemical mediators associated or released with allergic reactions produce symptoms that range from being mild symptoms, just having a runny nose, itchy eyes, watery eyes, to life-threatening, where we're having laryngospasm or where we're having bronchospasm and we're having difficulty breathing and we're going to need that EpiPen. So what's released are histamine and heparin and serotonin and prostaglandins and kinins. And on page 210, table 14.8, it talks about leukotrienes and all of these chemical mediators. So that's a good chart for you to look at, and in the old textbook it's found on page 219. So the next component says the parts of the immune system must work together, and you know all of those cells have to work together to ensure an adequate defense or an adequate response against the invader, whether it's a virus, a bacteria, or these foreign substances. And that is without destroying our own tissue. And sometimes we can have an aggressive reaction or an overly aggressive reaction that can lead to that anaphylaxis. So the function and production of immunoglobulins, and we know those are the antibodies formed by the B lymphocytes or plasma cells, and this is in response to an immunogenic stimulus that constitutes a group of serum proteins called immunoglobulins. So on page 206, table 14.2, table 14.5 in the old book on page 214. And so there are 5 classes in the lymph nodes: tonsils, appendix, the Peyer's patches in your GI tract or circulating in the blood. Antibodies of IgM, IgG, IgA, and I've already talked about these, have definite and well-established protective functions. IgE, I need for you to remember, are involved in allergic disorders and parasitic infections. And IgE producing cells are located throughout your respiratory and intestinal mucosa. So the GI and the respiratory tract are lined with those IgE producing cells. So important for you to remember for your test. So 2 or more IgE molecules can bind together to an allergen and trigger mast cells or basophils. These are also associated with allergies, to release those chemical mediators which produce allergic skin reactions, asthma, and hay fever. And the 2 components that are the major chemical mediators are histamine and heparin. The function of the antigens are divided into 2 groups: a complete protein antigen, a low molecular weight substance. Complete protein antigens include animal dander. So when I was sharing with you about being allergic to the cat, some of you have talked about being allergic to pollen and dust. If you're allergic to horse serum, all of these stimulate a complete humoral response or a B cell response that produces all those antibodies. So in an allergic reaction, the production of antigen-specific or IgE antibodies requires active communication between macrophages, and we know that those are major phagocytic cells. They can phagocytize more than once, and they live in your body for months to years. Your T cells, and for most often the T cell has to be sensitized first and brings it to the B cell. That CD4 helper cell brings it to the B cell for it to become sensitized and to start producing that plasma cell that produces all those antibodies. And then they both produce a memory cell, both T cells and B cells. When an allergen is absorbed through the respiratory tract, GI tract, or skin, the allergen sensitization occurs. The macrophage processes the antigen, presents it to the appropriate T cell. B cells that are influenced by the T cell mature into an allergen-specific IgE immunoglobulin secreting plasma cell and synthesizes and secretes the antigen-specific IgE antibody. So functions of some of those chemical mediators. Mast cells. Your book talks about this on page 210, table 14.8 in your new book, page 219, table 14.11, and these again are the mediators of allergic response. So mast cells have a major role in IgE-mediated immediate hypersensitivity and are located in skin and mucous membranes. When they are stimulated by antigens, powerful chemical mediators are released, causing a sequence of physiologic events that result in the symptoms of an immediate hypersensitivity. So I need for you to focus on if it's an immediate response or a delayed response. So there are 2 types of chemical mediators: primary, which are found in mast cells or basophils, and secondary, which are inactive precursors formed or released in response to primary mediators. So the primary mediators: histamine, number 1. Histamine. So you take an antihistamine to block the histamine response. And so before you go out into the world and you are exposed to all these allergens that you know that you're allergic to, you need to take your antihistamine first, because it blocks and stabilizes those mast cells. And also some of the newer drugs, the Singulair and Advair, they are leukotriene stabilizers, so they prevent the release of the leukotrienes and the response on your body. So histamine causes contraction of the bronchial smooth muscle that results in wheezing and bronchospasm. Now, a laryngospasm is life-threatening. So if I'm just wheezing, you're going to give me Benadryl. But if I'm really having difficulty breathing and say, I can't get enough air in, or air hunger or stridor, then you better pop me with the EpiPen. It also causes dilation of small venules and constriction of larger vessels that cause erythema or redness, we know, edema, and urticaria. And so then we also have an increased secretion of gastric and mucosal cells that can result in diarrhea, but the mucosal cells as well, we can have a runny nose. So that's rhinitis. Okay. The histamine action results from stimulation of H1 and H2 receptors found on different types of lymphocytes, particularly T lymphocyte suppressor cells. Which cells are those? That's right. You're so smart. I'm so proud of you. The CD8 cells, as well as basophils. H1 receptors are found predominantly on bronchiolar and vascular smooth muscle cells, and H2 are in your gastric parietal cells. So certain medications are categorized by their action at these receptor sites, and diphenhydramine or Benadryl, which is an antihistamine, displays an affinity for H1 receptors. Cimetidine or Tagamet, Zantac, Reglan, they have H2 receptors to inhibit those gastric secretions, especially in peptic ulcer disease, but also associated with an allergic response. Another chemical mediator is platelet activating factor, or PAF. This is a primary mediator as well. It's responsible for initiating platelet aggregation at sites of immediate hypersensitivity reaction, causes bronchoconstriction and increased vascular permeability. It can cause occlusion of the airway and greatly increase the mucus production. So we need to be careful in these patients. It activates factor 12, or the Hagman factor, which induces the formation of bradykinin. The next type of chemical mediator is also a primary mediator, prostaglandins. And I know that you know, if I ask you this question, what do prostaglandins cause? And you're going to tell me another P word, pain. Composed of unsaturated fatty acids, produce smooth muscle contraction as well as vasodilation and increased capillary permeability. The fever and pain that occur with inflammation are due in part to prostaglandins. And so that's why we give your patient what? An antiprostaglandin. So we give them an NSAID, or we give them a salicylate, or a COX-2 inhibitor actually helps. And this helps to decrease the fever and the pain. Okay. Secondary mediators, leukotrienes. These initiate the inflammatory response. They are one of the these substances, slow reacting substance of anaphylaxis, or SRSA, produces sustained spasm of the bronchioles, so bronchospasm or laryngospasm, and your patient must have what? What is the drug of choice for this? Epinephrine. Leukotrienes are 100 to 1,000 times more potent compared with histamine in causing bronchospasm. Important for you to remember. So patients who have anaphylaxis, it's going to be a good thing for them to be on those drugs that block the response of the leukotrienes. Many manifestations of inflammation can be contributed to the leukotrienes. So we have leukotriene receptor antagonist drugs that we're going to use, the Singulair, the Advair, Montelukast, and Accolate, Zafirlukast. That's a new one. So those are blocking the effects of the leukotrienes, and that's a good thing that we have those drugs now. Bradykinins cause contraction of the smooth muscles of the bronchi and blood vessels, cause increased permeability of capillaries, resulting in edema. So we have excess mucus and we have edema. Bradykinin stimulates nerve cell fibers and also contributes to pain. Serotonin is released during platelet aggregation. It acts as a potent vasoconstrictor and causes contraction of the bronchiolar smooth muscle. So all of these work together, primary and secondary mediators, to give you all those symptoms of an allergic response. Hopefully that it's going to be mild and you can catch it with an antihistamine versus going on into full-blown anaphylaxis. Okay, hypersensitivity reaction is on 217 in your old book and 209 in your new book. This is a definition. It is an abnormal heightened reaction to any type of stimuli. It usually does not occur with the first exposure to an allergen, so you're sensitized on the first exposure. So we're talking about primary exposure and secondary exposure, just like we were talking about when you have a primary immune response where you form all those antibodies, and the secondary response is quicker when you come in contact with that antigen again. Okay. So the reaction follows a re-exposure after sensitization in a predisposed individual. So there has to be some genetic predisposition or familial tendency for this to happen, for you to have those tendencies to develop allergies. Very important that the reaction is on re-exposure after the patient has been sensitized. So sensitization initiates the humoral response producing antibodies. Again, those are your B cells. Hypersensitivity reactions have been classified into 4 specific types of reaction. Actually, there's a 5th one. Most allergies are identified as either type 1 or type 4 hypersensitivity reaction. So the first one that we're going to talk about is called anaphylaxis, and on your handout it is type 1. And in your book on page 209 and in your old book on page 218, and this is table 417 in the 14.7 in the new book and 14.10 in the old book. And your handout, you need to have types of hypersensitivity reactions. Okay, so anaphylaxis or type 1 hypersensitivity in your book on table 14.7. It says this is IgE mediated. So what does that tell you? It is an allergic response. The antigen can include pollens, foods, drugs, dust. The antibody that's involved is IgE, important for you to remember. There is no complement. The mediators of injury, and these are the chemical mediators, histamine is number 1. Mast cells release the histamine and the heparin. Leukotrienes, again, all of those symptoms that your patient is going to be experiencing. And prostaglandins. Examples of type 1 hypersensitivity, allergic rhinitis and asthma. So that's your hay fever and asthma. Skin test, will and flare. Essentially, if you're allergic to mosquitoes, when they bite you and you get a big red bump and it itches, that's the histamine in there. And that's what an example of IgE-mediated antigen. So back on the PowerPoint, it says anaphylactic type 1 rapid hypersensitivity is an immediate reaction. It begins within minutes of exposure to an antigen. It is the most common type of hypersensitivity that individuals have. It's mediated by IgE antibodies, and there's increased production of IgE. And this is referred to as a type 1 hypersensitivity, and we know that it has to require a previous exposure. So I was exposed at some point to that specific antigen. So I was sensitized, or I was inoculated at that particular time. Just a side note, acute inflammation occurs when IgE responds to the antigen that causes a release of histamine and heparin and other vasoactive amines from those basophils and eosinophils and the mast cells. And that's what we're talking about, are those mediators of hypersensitivity. Again, remember that there has to be a sensitization stage, and then there has to be a secondary response. Again, remember that this is an immediate response. Your atopic allergies that we refer to as asthma, and your seasonal allergies are hay fever, insect stings, bee stings, wasp stings, hornet stings. Food allergies are associated with this type of hypersensitivity, and atopic dermatitis, and we'll talk a little bit more about that. So, plasma cells produce IgE antibodies. This is type 1 hypersensitivity in the lymph nodes, where helper T cells aid in promoting the reaction. The IgE antibodies bind to the membrane receptors on mast cells and basophils. During re-exposure, they bind to adjacent IgE antibodies, activating a cellular response, triggering degranulation and release of all those chemical mediators that are causing all of those reactions in your patient. Primary chemical mediators responsible for symptoms of type 1 hypersensitivity because of their effects on the skin, the lungs, and the GI tract. And when the chemical mediators continue to be released, there's a delayed reaction that continues to last for up to 24 hours. So if you have a patient who comes in anaphylaxis, they must be monitored for 24 hours because they can continue to have the release of histamine and heparin, and we will need to continue to administer the antihistamine and the H1 and H2 receptor agonist as the patient develops symptoms again or becomes symptomatic. On page 210, figure 14.6, Page 219, Table 1411. No, I think we've already talked about those. Those are the mediators of allergic response. What I want you to see is figure 14.6 in page 210 in your new book. And it identifies the steps in a type 1 allergic reaction. And so it shows you the cells that are involved. It shows you that on initial exposure, you're exposed to the allergen. And this figure is steps in a type 1 allergic reaction. It shows you where the B cell identifies the ragweed, and the plasma cell starts secreting IgE antibody in response to that allergen. And then those IgE attach to the mast cells. And the next time you are exposed to that allergen, the ragweed, it binds to the IgE and attached to the mast cell that triggers the release of chemical mediators from the mast cell. And so the chemical mediators cause the following symptoms in your patient. Need to remember these. In the intravascular compartment, can cause you to go into anaphylactic shock. And as far as the skin, urticaria, atopic dermatitis, wheal and flare reaction, that's your mosquito bite. Angioedema, that's where my eyes are swollen, my nasal passages are swollen, I have lots of mucus, my throat feels like it's closing in, my tongue is swollen, I may have some chest tightness. So I have rhinitis, I may have some asthma. What's another term for asthma? Wheezing. What do I need to get pretty quick? A Benadryl. As far as the GI system, as it continues, nausea, vomiting, cramping, pain, and diarrhea. And so all of these are signs and symptoms associated with this type 1 hypersensitivity reaction. Clinical symptoms are determined by 1, the amount of the allergen. How much exposure did I have? 2, the amount of mediator released. 3, the sensitivity of the target organs. And 4, the route that the allergen actually entered my body. So, Table 14.9 on page 211 talks about allergens that cause anaphylactic shock. I don't know what is the old page. This is allergens causing anaphylactic shock. I don't have the, yes I do. 211, page 211, figure 14.7 are the allergens. No, 14.7, that's clinical manifestations. So 14.7 is in the new book, Clinical Manifestations of Systemic Anaphylactic Reaction, pardon me. And I don't have what table it is. It's the picture of the guy that's having an allergic reaction. That's where I want you to look. And right below that should be table 14.9, which is the allergens that cause anaphylactic shock. So, drugs in type 1 hypersensitivity: penicillins, sulfonamides, insulins, aspirin, tetracycline, local anesthetics, chemotherapeutic agents, cephalosporins, non-steroidal anti-inflammatory drugs. So if you're allergic to aspirin and NSAIDs, that's pretty bad. Foods that can cause type 1 anaphylaxis: eggs, milk, hello, we know nuts, peanuts in particular, shellfish, again, so there's your iodine and your betadine, fish, chocolate, oh, that would be such a bad allergy to have chocolate and strawberries. Treatment measures that can cause anaphylaxis: blood products, so if your patient received blood components, we're going to talk about transfusion reactions, iodine contrast media, allergenic extracts and hypersensitization therapy. So sometimes you can have a response to your allergy drops or allergy shots. Insect venoms: wasps, hornets, yellow jackets, bumblebees, ants, any sting that can predispose you to an anaphylactic reaction. I guess the most profound one I can think of is in My Girl, when oh, I can't think of the little boy's name. I know it was initials, but anyway, TJ or JR or something, when he had all the bee stings and he died because of that. Sad little part in that movie. It was just a sad movie altogether, but it did end well. Okay, getting back to this, allergens causing anaphylactic shock: animal sera, tetanus antitoxins, rabies antitoxins, diphtheria antitoxins, snake venom antitoxin. Also, your patient can have an anaphylactic reaction to the natural rubbers to the proteins that are in latex. And so you can have a latex allergy that's identified as a type 1 hypersensitivity. Okay, let's see what else I need to tell you. We talked about all those. Okay, very good. So, a type 1 hypersensitivity response results in atopia, or an allergic disease, in 209 in your old book, or 219, and 210 in your new book. There's a genetic predisposition to susceptibility, so somebody in your family already has allergies. That's your mother or your dad, and you got them. Disorders that are characterized by atopic include anaphylaxis, allergic rhinoconjunctivitis, atopic dermatitis, urticaria, and angioedema, GI allergies, asthma, and latex allergy type 1 reaction. Again, this is to allergy to the protein in the powder. Okay, anaphylaxis is a clinical response to an immediate type 1 immunologic reaction between specific antigen and antibody. It results from the IgE antibody, and again, this is on a subsequent exposure because they had that initial challenging dose or sensitization. Remember that. In your book on page 218, and in the old book and 210, in the new book, table 14.9, we just went over those on page 211. Okay, in the old book, it's table 14.12 on page 219. This is also referred to as an acute systemic type 1 reaction in a highly sensitized person, and this is someone after they've been inoculated or after they've been sensitized to a specific antigen. The reaction begins within minutes of exposure and may be almost instantaneous. This patient needs to have a medical alert bracelet, and they need to have an EpiPen on them at all times. The anaphylactic reaction occurs as follows. The antigen attaches to what? IgE. Again, that's on the first exposure. It's fixed to the surface membrane of the mast cells and basophils. It causes the target cells to become activated, and that's upon the first exposure. On the second exposure, the mast cells and basophils release all these chemical mediators, causing all of those changes in your patient. And this is the signs and symptoms or clinical manifestations that are occurring in your patient. That's figure 14.7. So if you look at this little gentleman, he has a headache, he feels dizzy, he's experiencing paresthesia, a feeling of impending doom, important for you to remember. So that would be, this would be a good select all that apply. He's got pruritus. What is pruritus? Yes, itching, that's right. Angioedema, that's all that swelling. Erythema, redness, urticaria. He's got some hives going on here. He's hoarse, he may be coughing. He has a sensation of feeling that his airway has been constricted or narrowed. He may be wheezing. If he develops stridor, we got to give him that EpiPen. Dyspnea, tachypnea, respiratory, okay, death. We got to give him the Benadryl and call 911 if you have a patient experiencing these symptoms. Give him the Benadryl, call 911, or you can do that all at the same time. And if they have an EpiPen, I'd pop them with the EpiPen and wait for the EMS to get there. As far as the cardiovascular system is concerned, hypotension, dysrhythmias, tachycardia, cardiac arrest. Okay, so your patient is in a state of shock, and they may have a cardiac arrest on you, and you're going to be performing CPR, so you better call 911. As far as the GI system is concerned, abdominal cramping and pain, nausea, vomiting, diarrhea. So those are classic symptoms of type 1 anaphylaxis. Let's see, did I cover everything on that page? So an anaphylactoid or an anaphylaxis-like reaction is clinically similar to anaphylaxis. However, it is not mediated by antigen-antibody interactions. It's a result from substances acting directly on the mast cells or tissues that cause release of those mediators. An anaphylactoid reaction may occur when food, medications, exercise, and cytotoxic antibody transfusions occur. The reaction may be a local reaction or it may be systemic. Remember I talked about the wheel and flare, and that's an example of your mosquito bite. Local reactions include urticaria and angioedema, or the hive or the welt, and angioedema at the site of exposure. So angioedema is your eyes are swollen, your nose is running, you throat may feel scratchy, your tongue may feel scratchy. Excuse me, although possibly severe anaphylactoid reactions are rarely fatal. So, however, systemic reactions occur within 30 minutes of exposure involving the cardiovascular, respiratory, GI, and integumentary organs. And so clinical manifestations include mild systemic reactions consist of peripheral tingling and sensation of warmth, possibly accompanied by fullness in the mouth and throat, nasal congestion, periorbital edema, you know where that is, pruritus, sneezing, tearing. Onset of symptoms begins within the first 2 hours of the exposure. Again, usually within 30 minutes. And again, the first drug that we're going to give them is that diphenhydramine or that Benadryl. And we're not going to give the EpiPen until they start having, again, those difficulty breathing. Moderate systemic reactions may include flushing, a feeling of warmth and anxiety, again that impending doom, itching in addition to any of the above symptoms. More serious reactions include bronchospasm and edema of the airway or larynx with dyspnea, coughing, wheezing. Onset of symptoms is the same as a mild reaction. Again, we must give them epinephrine. Severe systemic reactions have anaphylaxis versus anaphylactoid. So anaphylaxis, abrupt onset, same signs and symptoms, air hunger, stridor, wheezing, hypotension, signs and symptoms of shock, must intervene immediately, must have that epi. It progresses rapidly to bronchospasm, laryngeal edema, severe dyspnea and cyanosis, dysphagia, abdominal cramping, vomiting, diarrhea, seizure may occur, rarely cardiac arrest and coma, and of course death if they're not treated, so we need that epinephrine. On page 214 in your new book, it talks about emergency management, and this is table 1411, and in your old book it's on page 223, and it's table 1414. And so it talks about anaphylactic shock and what do we need to do. So after we have inhaled or been injected with or topically exposed to substances that produce profound allergic response, interventions initially ensure a patent airway. Hello, ABCs. Administer high flow oxygen. Well, you know, you're not going to have that in the classroom or out in the field, and this should be 4 to 6 liters. If it was an insect sting, then we try to remove the stinger. In the emergency room, they're going to need IV access. They're going to get epinephrine 1 to 1,000 or 0.01 milliliters per kilogram. IM, repeat every 5 to 15 minutes. Nebulized albuterol or Proventil, diphenhydramine, Benadryl, IM or IV, and initially you get it in a PO. Corticosteroids, methylprednisolone or Solumedrol intravenously, so y'all need to know about that drug. For hypotension, you're going to put them in that shock position. May administer epinephrine 1 to 10,000 or 0.1 milliliter per kilogram every 2 to 5 minutes IV. Maintain their blood pressure with IV fluids, volume expanders, those vasopressors, the dopamine or intropin. Ongoing monitoring, vital signs, respiratory effort, O2 sats, level of consciousness and cardiac dysrhythmias or rhythm. Anticipate intubation with severe respiratory distress. That would be scary to be on a ventilator just because you had an allergic reaction. Anticipate cryotherapy or tracheotomy with severe laryngeal edema, and that's where we are. Very, very scary situation. Okay, so how do we prevent this? Well, you've got to avoid the triggering allergen. Can we always do that? Especially if it's dust or dust mite, or if we have animals in our house and their dander is all over. So I know that I can't pet a cat or a kitten that I can't go straight and wash my hands. I can't touch myself anywhere because I'm going to have a reaction to that kitten. Always carry an emergency kit containing epinephrine. Carry that EpiPen. Where is it? It should not be in your car. It needs to be on your person somewhere. A medic alert bracelet, or, you know, I wish everybody just get a little chip and we know what your allergies are. And anyway, may need to undergo desensitization. Again, that's going to be your allergy shots or drops where they give you a little bit of the allergen, and we want it to bind with IgG, not IgE. So we need to give them that allergy. shot. We want them to bind with IgG, not IgE. I think we already talked about all these, so I'm just going to skip on through some of these. Allergic rhinitis is just an example of atopic reactions. It's in your book on page 210, in the old book on page 218. This is allergic rhinitis or hay fever or asthma. The sensitization begins by ingestion or inhalation of an antigen. On re-exposure, so first we had to be sensitized, our nasal mucosa reacts by, there's a slowing of the ciliary action, there's edema, there's leukocyte eosinophil intration, there's inflammation of the nasal mucosa. Chronic allergic rhinitis is the most common form of this. I got a runny nose, my nose is itching, my throat might be itching. Remember that there's a genetic or inherited tendency associated with this type of disorder. Histamine, major mediator. What do I need to give my patient? Diphenhydramine Benadryl. Tissue edema results from vasodilation and increased capillary permeability. When it's untreated, complications such as allergic asthma, chronic nasal obstruction, chronic otitis media with hearing loss, anosmia, which is an absence of the sense of smell. That would be a good term for you to remember. In children, they have orofacial dental deformities, and in children they have that salute sign where they're itching their nose because it itches with their fingers going up, and they have that little ridge across the top of their nose. So early diagnosis and adequate treatment is essential. Because allergic rhinitis is induced by airborne pollens or molds, it's characterized by the following seasonal occurrences, and you know that. What are you allergic to, and when do you have those symptoms? In spring, summer, or fall, and what's going on? Clinical manifestations: stuffy nose, clear watery nasal discharge, or viscous mucus, intermittent sneezing, nasal itching, dry cough or hoarseness. May complain of headache, pain over the paranasal sinuses, and epistaxis. What is that? That's right, a nosebleed. And your patient can also experience some chest tightness associated with this. So medical management of type 1. We're going to provide relief from symptoms, so we got to give them the antihistamine. So what is the drug of choice? Okay, so diphenhydramine, which is Benadryl. May also give them some hydroxyzine or Vistaril, or promethazine, which is Phenergan. We're not going to give that IV though, remember that? Okay, we're going to give them those H1 and H2 antagonists. And hopefully we can give all this before they have exposure, but if they're already exposed and experiencing symptoms, we're going to need to give them these medications. It talks next about mast cell stabilizers such as intranasal cromolyn sodium or nasal crom. So if you have this type of allergies, you need to, before you go outside, you need to squirt the nasal crom up your nose. You have to have a doctor's order for that, and take your antihistamine. Pardon me. In your book on page 501, and this is table 27-2, it talks about drugs that are used to treat this. In the old textbook, it's page 522. Excuse me. Table 27-2. Corticosteroids may also be used. Excuse me, in more severe cases. And immunotherapy is indicated only when IgE hypersensitivity is demonstrated to those specific allergens that your patient cannot avoid, so dust. So again, remember, we're going to give the allergy shots or drops to stimulate IgE response, not IgG response. Stimulate allergy shots, drops, IgG response, not an IgE response. So again, serial injections, gradually increased or drops, and of course practice avoidance of the allergen. Teaching: your patient needs to know the side effects of medications to report urticaria, difficulty breathing, headache, dry mouth, palpitations, or dizziness. And you need to caution them regarding the drowsiness associated with taking any of these antihistamines and any of these drugs. So I'm going to stop now. We'll finish talking about the rest of the type 1 sensitivities on Monday after your test. Happy studying. Do well on your test.